Good morning and good afternoon. Welcome to our January Wednesday webinar. Today's topic is about value-based and HCC coding in a changing environment. We're happy to have our special guest, Nancy Enos from MGMA Consulting, here to discuss the ways value-based payment and hierarchical condition categories are driving the direction of reimbursement away from fee-for-service and towards new models that have incentives for patient care and quality. So with that, I'll hand it over to Nancy.
Thank you, Brett, and thank you to those of you who are on the call for joining us today. I hope that last week wasn't too busy getting back to your offices after the holidays, and now this is a good time to start to look forward now that we're really hitting our stride in January to see what's new. And HCC risk adjustment coding is really something that we've been hearing about for a few years. Maybe we put it on the back burner and knew that it was something that we needed to talk about in the future. And it's 2018 and the future is here. Effective last October, there was another update to the ICD-10 coding classification system. Not the biggest update ever, but there were only 620 diagnosis codes that were changed. There were 360 that were new, 226 that just had their descriptions revised, and 34 codes were changed. They previously were valid, and now they're invalid because they have subclassifications below them. So there are a couple of different codes that you would choose from instead of those previously valid codes because of the new subcategories. An example is what you knew as a valid 4-character code is now going to require a 5th character. So that's a little bit of a new term for us in the coding world, but be aware that the previous codes in that list of 34 have changed. They won't be valid anymore. There are also updates to the coding guidelines that will impact medical record documentation, which we'll talk a lot about in this hour, as well as your code selection and the code sequencing. And adhering from the guidelines is really part of correct diagnosis coding because under HIPAA we have to use valid diagnosis codes or valid code sets in all healthcare settings. So we always start out with those general reminders about doing a good job with coding, particularly with diagnosis coding. I've been doing coding, teaching coding in the medical billing field for 40 years, teaching coding for 20 years as an instructor for AAPC. And the ICD-10 change was the biggest change ever, and it really brought a new level of expectation to physician documentation. When I talk about coding, I'm really thinking about what's in the note. And it gives a much more transparent clinical footprint, so anyone who reads the note knows exactly what that doctor was thinking about that patient because of the level of detail that it takes to support these ICD-10 codes that tell the whole story. So this will benefit the government payers, the insurers, the hospitals, the health systems, and the medical groups. Everyone who shares this information is now getting more granular, more detailed data. And now we're also seeing it used how to determine accurate and fair physician compensation and reimbursement for goods and services, fair to the payers and fair to the providers. And the way that happens is medical groups are signing contracts that will adjust payment for the contract year based on quality measures. We are so used to looking backwards to fee-for-service and what diagnosis is required to support a CPT code to get a claim paid. But looking forward now, it's all about value, meaning the government wants to get the most for its money, and physicians want to make sure that they're getting enough to cover the work that's being absorbed by patients who have a number of chronic medical conditions. So accumulative care is something that we've heard about on the hospital side. If you've ever done any Part A billing, we know that the facilities use diagnosis codes. The term DRG might be slightly familiar. The diagnosis-related groups, the sicker the patient, the higher the daily rate the hospital gets for having the patient as an inpatient for their episode of care for something like pneumonia. So the diagnosis code has always driven the Part A reimbursement for the facility. Now it's filtering over to the Part B or the professional side for the physician's billing, taking into consideration how sick the patient is as well as their socioeconomic factors, the patient's age, their gender, medical conditions, even their social conditions. Where does the payer get all their medical chronic conditions, it's the diagnosis codes on those fee-for-service claims. So it's really taking that information to another level. There are a couple of different programs. The Medicare Advantage plans base their incentive payments on risk adjustment factors, or RAF scores. Under MIPS and MACRA quality programs, they're also taking these diagnosis codes into effect because they're paying based on outcomes. So diagnosis coding is really going to have an impact to fund the insurance plans. On the insurance side, the risk adjustment model is in place to predict the future healthcare costs for enrollees. How much is it going to cost to cover the care for these patients for the next year? So CMS is then able to provide capitation payments or extra bonus money in order to make it fair to enroll the patients who are sicker and not just the healthier individuals who cost less to insure. And this is something that we've seen on the news, a lot of discussion about the dismantling of the Obamacare in terms of the insurance companies' pricing is not working out because the healthy patients didn't enroll and the sicker patients did, and then the money ran out and the prices went up. So it created a big problem. So the government's looking at these plans, saying that capitation payments will help these health plans to enroll both healthy patients and patients with chronic conditions who are more seriously ill by providing some additional compensation based on information analyzing those chronic conditions, so sort of making up for the extra expense of those sicker patients. And we'll have a couple of slides showing you actually how that math is going to work out in some models. HHS has payment goals. They want to get the best value that they can from the tax dollars, so they want to drive down the cost of health care rather than continuing to reward volume regardless of the quality delivered. So the 99223s, the 99215s, the critical care codes, those are the highest reimbursed codes in each of those E&M sections that we're familiar with, but they're paying higher for volume. The ACOs, the Accountable Care Organizations, then started to look at bundled payments. There's advanced primary care models and primary care medical homes that also want to prevent expenditures by helping to keep patients well and then sharing in those savings. So there's a financial incentive to both the insurer and the healthcare provider. By shifting this cost, the goals were to move 30% of Medicare patients into these alternative payment models by the end of 2016, and up to half of them by the year that we're entering in 2018. Half of Medicare enrollees should be off of traditional Medicare and into some other model. And going further, they wanted to look at the 85% of the Medicare payments tied to a different model, taking quality or value as some kind of a component of the physician compensation. And we've seen under MIPS and MACRA these penalties and incentives being paid, and those are also maturing in 2018, and there are models that are continuing to go out a few years ahead as well, till 2025, I believe. And the alternative payment models include accountable care organizations, the Medicare shared savings, bundled payments, and the primary care medical home. All ideas that are aimed at increasing the quality of care and decreasing the cost of providing that care. Under MACRA, which is the Medicare Access and CHIP Reauthorization Act, there are 3 different programs. We just talked about MIPS, and MIPS really rolls up what we knew as the Physician Quality Reporting System, PQRS, the Value-Based Payment Modifier, VBM, the Clinical Practice Improvement Model, and meaningful use of electronic health record technology. So all of those programs under MIPS have sort of phased out, and they're being rolled into the next version. Alternative payment models have also been another choice, and going forward from 2019 to 2024, some payments providers will receive a lump sum payment, and this does increase the transparency of the physician-focused payment models. And going out to 2026, they will offer higher annual payments for practices that join an alternative payment model. And the criteria for those models is to offer coordinating care improving quality, and reducing costs. So all of these goals are very similar, and one of the ways that they look at the data to see how the risk is affecting the outcomes is by tracking diagnosis codes. And this is not that is something that is new. The Hierarchical Condition Category models, or HCC, has been in place since 2004. So 14 years ago, Medicare Part C, which is the Medicare Advantage plans, or the HMO model, offered this risk adjustment model to identify patients with serious, acute, or chronic illnesses, and they assigned a risk factor score to the beneficiary, not to the doctor who takes care of that patient, but this is targeted towards the beneficiary, taking into consideration the patient's demographics. Do they live alone? Are they on disability? Are they mobile? Some of those things, as well as their medical history from diagnosis codes. Then the government contracts with these for-profit insurers, such as Humana, United, and so forth, to manage the health care for these patients. And they pay the insurers a yearly fee for each member they pay. So that's what I mentioned earlier when I used the term capitation. The way they calculate the capitation for each patient is the higher the risk score, the higher the annual capitation fee, or the funding that goes into paying for the cost of care for that patient. Under the traditional Medicare fee-for-service model, the Medicare enrollees or beneficiaries pay a monthly premium to CMS to buy their insurance, whether or not they visit a doctor. So this is something you can imagine is for a fairly healthy person, just the way that they have their card in their wallet. They're receiving funding from U.S. taxpayers to CMS, and they turn 65, they get their Medicare Part A and Part B cards. If they see a doctor, the doctor sends their $1,500 claim to CMS to get paid based on the physician fee schedule according to the CPT code that they reported was provided, as long as the diagnosis code justifies medical necessity. And then CMS pays the doctor. That's the end of that line item for a fee-for-service claim. It doesn't matter if it's a procedure that they performed, such as colonoscopy, a lab test, a diagnostic image, or a surgery. It all works the same. It's just based on that one line item fee for each service. Under the Medicare Advantage risk-based model, the members will also pay a premium to CMS in order to have their Medicare Part C, and they often have a separate premium to a private insurance company to enroll in that plan. The member sees their doctor. The doctor sends a copy of the claim to the private insurance, who pays the doctor for that, the fee for service, but CMS also pays the private insurer a base rate for each member. If the private insurer tells CMS that the member requires treatments for certain conditions, then CMS will pay the insurer more. So you can see the member is paying the insurer and CMS, and then CMS is paying the insurance company as well as the doctor. So the money exchange is very different in this risk-based model. The number of patients who are enrolled in these plans has increased significantly since 2010, when there were 11 million. Nearly a third of all Medicare beneficiaries now have chosen Part C plans over their traditional fee-for-service Medicare Part A and Part B. And the government pays the insurers, on average, about $10,000 per year per person under this model. That $10,000 is a baseline. Now, each patient is assigned a score, which is called the Risk Adjustment Factor, or RAF score. These scores are based on demographics, such as the patient's age and sex, their Medicaid or disability status, the total of all chronic conditions, and disease interactions. The RAF score identifies the patient's health status, so the lower the RAF score indicates a healthy patient, the higher the RAF score, the sicker patient. And the baseline for that $10,000, the patient has a score of 1.0. The RAF scores are additive, so the way that the hierarchical condition coding affects the payment is that it looks at all qualifying diagnoses that are reported in the RAF score. And all qualifying diagnoses is something that we need to really understand, because there are probably about 9,000 diagnoses that map over to 79 or so HCC categories, so not every diagnosis code is going to count towards the patient's RAF score. And not every diagnosis code can be reported, so we'll talk about that as we go along as well. So only qualifying diagnoses are reported and included in the score, and the risk score factors are added to get a total score. So if a patient sees a number of doctors, all those RAF scores are going to be added up together to indicate the higher RAF score for that patient. Remember, it's not the score for the doctor, it's the score for that individual patient for that year. The RAF scores are predictive, so the codes that are reported in 2017 determine the payments for 2018. And in 2018, these will be accumulated to fund the insurance company to pay for the patient's care in 2019. It's very important, because these start in January, to remember that the patient's health status has to be redetermined every year. If you saw a patient recently in December and sent in a qualifying diagnosis, it's not going to count for the patient for this year, for 2018. The RAF for each patient is reset every year on January 1st, so you have to see the patients annually and report all the qualifying diagnoses within that calendar year in order for it to be counted in their total RAF score, because they do have to be reset and they have to be re-reported every year. There's no carryover from prior year's diagnosis code data. Once the patient has all these codes put in, the payment is also made per HCC category. So, for example, if the category is diabetes and the patient has 3 or 4 diabetes codes, because now the E11 codes are so specific with the number of complications the patient has, such as diabetic retinal problems, or diabetic neuropathy and diabetic skin problems and diabetic CKD, if those are all attributable to one HCC category of type 2 diabetes complications, that payment is going to be made for that patient being in that category, not having several diagnoses that map to that category. So that's important to remember, that it's per category, not per diagnosis code. The best way to get these patients in the calendar year of 2018 is to make sure that they come in to see you for an annual. The health risk assessment is very important. It's also a covered Medicare service, so you should be taking advantage of that and getting the patients in for their annual wellness visit. I realize that it's not a physical, and there's a lot of billing questions about having the patients get coverage for their physical. The annual wellness visit is actually required to have the patient fill out a risk questionnaire and answer questions about depression and cognitive impairment and safety in the home. But it's a great opportunity to get the patient in and to go over the status of all of their chronic conditions, and having a good, thorough visit that documents everything, completes and updates their medical record, and gives a listing and gives you a chance to be very specific about their diagnosis coding. I know one practice in New Hampshire that has a nurse practitioner who is very focused on their geriatric population, and they actually call their elderly patients, schedule their appointments for the annual wellness visit with this nurse practitioner, who goes over and updates the electronic medical record, makes sure that all the appropriate HCC codes are reported for that visit, and then meets the criteria for billing the annual wellness visit. It works out very, very well, because that way nothing falls through the cracks and they get it all done on that patient once a year. And then when the patient comes in to see the doctor, the patient can be addressing their chronic conditions, such as their COPD and their diabetes and their other medical ailments that need the doctor's attention. So this slide is going to show us a little bit about how the diagnosis codes affect the payment. I mentioned that the patients who are fairly healthy have a RAF score of 1.0, and that will give a baseline payment from CMS to the insurer to cover the care for that patient. And then the insurer will split that payment among the different providers who see that patient. So this is a very short note, just for the purposes of giving an example. The patient is 64 years old and disabled, so we have that demographic information to start with. I apologize, my yellow highlighting is a little bit off. I had to change the format of my slides for this. She's a type 2 diabetic. So you can see the first two lines are filled in already, the 0.395 and the 0.085, because of her age and her disability status. Now, the first diagnosis code that we see in the second column is E11.9, so that shows that she has type 2 diabetes, and that gives a risk adjustment score of 0.121, because it's not a complicated diabetes code, and the annual payment from CMS to the insurer will increase by $1,162. But then we look at all three of them together with the two demographic values, and the total payment as a baseline for this person is $5,741. Then we take a look and see that she also has congestive heart failure and stage 4 chronic kidney disease. So that changes this uncomplicated diabetes code to type 2 diabetes that is complicated by chronic kidney disease. That puts it in a different HCC category of 18, and the value doubles to 378, and the payment increases to $3,629. Then we look at the N18.4 for the stage 4 chronic kidney disease. That has a value of 0.230 and increases the amount paid by $2,208. So now, by being more specific about the comorbidities the patient has with their type 2 diabetes, we have increased it by more than twice. So we go from 5,000 and change to 10,416. So being specific with diagnosis codes are very important. She has a BMI of 56, and she's obese. So we know that the Z79.4 BMI code should be reported, and that also is going to increase the RAF score by 0.121. That falls into HCC category 19. And then the patient also has the congestive heart failure, and the congestive heart failure is a diagnosis code of I50.22, and that is a complicating condition, so that adds 0.375 for $3,619. So now with that obesity and heart condition reported, we went from $10,000 to $15,000. So you can see how just this very short note, by making sure we cover everything, we've gone up to $15,000. So have we coded everything that we can in this? Let's take a look. She's obese and on insulin, so E66.01 and the Z68.43 for the obesity and the BMI. The Z79, I'm sorry, that is going to be for the patient who is getting dialysis. So the dialysis increased it up here. The heart failure, the obesity, E66.01, the BMI of Z68.43 for her BMI of 56. And she's paraplegic. The paraplegia code is G82.20. She also has the paraplegia is going to add another code, so now that changes all of this to 32,726. So the total RAF score is 3.4. We said the normal healthy person's RAF score is 1.0, and this is 3.4. So we said that 1.0 would be about $10,000, and this is over 3.4, so it's $32,000. So that roughly calculates out to about $10,000 per point in the RAF score. Not a lot of documentation here in the note. This is a very short note as a sample, but you can see the number of diagnosis codes that are supported in that note, how many HCC categories on the left have been mapped by those diagnosis codes, resulting in a RAF score and higher annual payments. how can you increase those payments to your practice? If you're contracting with the Medicare Advantage plans and they are paying your providers an annual bonus, now it's January, you want to make sure that you bump up and maximize those payments for the coming year. Identify the HCC categories that are clinically meaningful to your practice. This is one very carefully crafted example because I knew what HCC categories had a lot of value in them, so I made the note fit the categories. In the real world, in your practice, you can't do that, but what you can do is use a list of HCC categories that you can get on the CMS website or using software like Encoder Pro or the AAPC's coding tools. Look at the HCC categories and look at the diagnosis codes that map to those categories and see how that compares to your current diagnosis code utilization lists in your computer system. What chronic diseases do your sickest patients have? You could even involve your nurses and your doctors in this discussion so that you can really pick out HCC categories that will apply to most of your sickest patients in this Medicare Advantage population. Look at the specific diseases and conditions. They are grouped to each HCC categories, so there are more than 9,000 ICD-10 codes that map to the 79 current HCC categories in the risk adjustment model for 2018. There are diagnosis codes that are excluded from mapping where they do not predict future cost, or they're vague, or they're variable in their diagnosis, their coding, or their treatment. So symptom codes like fever or osteoarthritis that doesn't necessarily require any treatment aren't really going to be codes that you will find mapping to an HCC category. So start with the categories first, drill down to the diagnosis codes that are mapping to those categories that pertain to your patient's care, and then start using those diagnosis codes. Some examples of the common HCC categories are listed here. I mentioned CKD and diabetes in the example that I showed you. Hypertension, peripheral arterial disease are also cardiovascular diagnoses that have categories. Some of the psychiatric categories include depression. Some of the neurology categories include stroke, seizures, Parkinson's. There are a lot of different neurologic conditions that have HCC categories. Other chronic conditions, patients who have a history of a heart attack, patients who have status because they're on renal dialysis or they have a tracheostomy or they're dependent on a respirator are all going to have higher risk adjustment factor scores. Status, don't forget things that don't change over time but do impact a patient, such as having had an amputation in the past. They will always have that amputation, but you do need to report it as a diagnosis code once a year, and the status that the trunk is well healed, and so forth. Also, a patient having a history of an organ transplant, that status has a diagnosis code that will map to an HCC category, or HIV asymptomatic is a status, of course, that will impact the cost of the patient's care. Diet such as protein, calorie malnutrition, other endocrine abnormalities, obesity also will map, and substance abuse will map to an HCC category. This is just a very brief list. As I mentioned, there are 79 categories, so you should take the time to look at a valid list for this year and then drill down. Once you've decided what categories you're going to aim for as your reporting goals for the year, make sure that you're compliant in your diagnosis coding. Don't just start throwing codes on your claims. You need to follow the official ICD-10 guidelines. You need to make sure that your note is sufficient enough to support that a condition was addressed during a visit. Sometimes we'll see that the patient's medication list says that they're on prednisone, and the doctor knows the prednisone's for asthma, so reports the diagnosis code for asthma, but asthma wasn't addressed during that visit, and it wasn't noted in the assessment as the reason for the visit as reportable diagnosis. So a condition that you can assume was treated because the patient's on medication for it, whether it's prednisone or something like hypertension medication or thyroid medication that the patient's on for life isn't enough to support a diagnosis code. Just having the patient being on medication for a condition doesn't validate that the patient has the condition. You need to go beyond that in order to have enough documentation in the note about addressing and treating that condition. Similarly, the patient who has some kind of test, whether it's a lab test or a diagnosis of pneumonia from a chest x-ray, that report doesn't confirm the diagnosis in the note. The note has to still say that the patient was seen for pneumonia. So the acronym MEAT, M-E-A-T, answers the question of, do I have enough in the body of this note to report this as a reportable diagnosis? Was this condition monitored? The reason for the visit in the chief complaint? Was it evaluated in the HPI, in the exam? Was it assessed, the status of chronic conditions, or was it treated? So monitored, evaluated, assessed, or treated conditions that are documented in a note qualify as a reportable diagnosis code for that visit. Don't report a diagnosis code that wasn't addressed during the encounter or that wasn't documented in the note. Sometimes I'll see problems with that when we do audits. Also, don't forget to include all the qualifying diagnoses. One of the biggest ones that I see not reported is BMI. Anytime you have a diagnosis of a patient being overweight or obese, those E codes should always be accompanied by the Z68 status, which drills down a little further to specifically say what the patient's BMI is. And those should always be reported in a twosome, the obesity code and the BMI code. And the BMI code will drive the reimbursement. Hyperlipidemia, unspecified, is something that, sometimes the patients will have lab work, they'll have medication, but it's not reported as a diagnosis. The uncomplicated diabetes, sometimes we see that as an overused code, especially when the patient has additional codes reported for type 2 diabetes with complications. Hypothyroidism, again, the unspecified code, there are better codes to use for that. Depression now has more specified codes as to the episode and the severity. AFib now has 4 different codes, so unspecified AFib is not a good code. Unspecified obesity, there are only 5 other codes, I believe, for obesity, so it's not hard to be specific and use a valid obesity diagnosis code because it is a common code. Asthma coding also now became very specific as to mild, moderate, or severe, and the episode of care. Anxiety, similar to depression, also needs more specificity. The heart failure codes are very specific as to what type of heart failure. Anemia needs to be more specific to the type of anemia. Erythematous conditions also have to be more specific. So these are often problems with the diagnoses that we see, and they'll have a negative impact on your RAF score and reimbursement. From an auditing perspective, we often see that there are missing diagnosis codes that could be reported, such as that BMI code, but isn't. Or we see diagnoses that are billed that have no documentation to mention them in the note whatsoever. And that's really something that you want to focus on by doing audits and then speaking to your providers, reminding them. Sometimes chronic conditions are not coded, and that's a billable diagnosis, or sometimes they're not assessed. During that annual wellness visit, it's a great time to get the status of those conditions. Or there's not enough specificity on the disease. Patient's diabetic and on insulin, the documentation doesn't show whether it's a type 1 or type 2 diabetes. And you can't assume anything from a note. You really have to ask the doctor to specify what type of diabetes. And the cause and effect relationship between underlying conditions and complications that developed as a result of those conditions. When you read the terms something is due to pneumonia or associated with cancer or manifested by asthma or secondary to arthritis, those kind of things, that means that you should always have 2 diagnosis codes unless there's a combination code existing, such as the diabetic complication codes. the cause and effect really does link two diagnoses together, and some of them are listed as a primary diagnosis, some are always listed as a secondary diagnosis. It's very important to understand that code sequencing based on those cause and effect relationships between multiple conditions. The use of history of codes, history of breast cancer when the condition is currently being treated, or vice versa, the condition of breast cancer being reported when the patient has completed their treatment and has been declared to be cancer-free, and they're coming in for a serial observation just to make sure that there's no recurrence. There's sometimes a confusion between current conditions and history codes, and there are less history codes, so there are less specified codes, but it still is important to make sure that you're using those properly. The diagnosis in a medical note should always be listed in the assessment and plan in the body of the note, summarizing what the provider is seeing for the problems addressed that day. The problem list sometimes is at the top of a note, or it sometimes is in a different section in the medical record, and that usually is a list of the patient's history, the problems that the patient has had in the past or has as current conditions. You cannot code from a problem list unless that problem was also addressed in the body of the note and in the history of present illness and in the assessment and plan as to what was done that day. So that's one very important thing. Sometimes I'll see the problem list as the source for diagnosis codes, and that's not correct. We already mentioned the medications being in the medication list for a condition, but the condition not being mentioned or linked in the note. Lisinopril for hypertension in the medication list isn't enough to say that the hypertension was managed, evaluated, assessed, or treated during that visit that day. The BMI status and the level of obesity, mentioned again, but worth mentioning a couple of times because of the prevalence and importance of that type of coding. In the status of cancer, whether it is currently being treated or a history of cancer. Other health statuses, the presence of a coronary artery bypass graft. If a patient has had a double or a triple or quadruple bypass in their past, and that is assessed, the patient's heart is examined, and that's part of the assessment, there is a reportable diagnosis code, and that certainly does elevate the level of complications for that patient. The same thing with amputations. The amputation could have been a long time ago in the past. There's no change to that. There's no infection to the site. There's nothing treated. But if it's assessed during an annual visit and the doctor mentions it, then that qualifies as a reportable diagnosis. The same thing with the status of any congenital diseases such as Down syndrome or transplant status. The patient has had a heart transplant, a kidney transplant in the past, and they're doing well. Is adequate documentation for updating the status on an annual basis for that patient who's had an organ transplant. And all of them are important reportable diagnoses that link to HCC categories. When a patient is on medication for long term, some medications the patients are put on for life. Examples are Coumadin, aspirin, insulin, Synthroid for hypothyroidism, and so forth. There are many medications that fall under this. There are status codes for long-term use of medications just for the type of medication, not for each medication specifically, but you can use those Z codes for long-term use of medication for those chronic diseases as long as the patients had that condition assessed during that visit. Aside from the reasons the patient is being seen and the patient's diagnoses that they carry, there are also pertinent family risks that elevate the cost of care for a patient, and there are social risks that elevate the cost of care for a patient. For example, if a patient has a family history of cancer, diabetes, hypertension, myocardial infarction, family history of sudden cardiac death, or family history of congenital diseases, that patient may require more surveillance or screening. Social elements, if a patient is homeless or has some other social challenges that make it difficult for them to take care of themselves, that will have an impact on the cost of rendering care to that patient as well. Acquired organs or acquired amputations, make sure that anything such as a patient who's a recipient of a kidney or amputation of a toe, all of those kind of things, not necessarily recent, but annually assess them. So just a reminder not to list any diagnosis codes from the problem list. If it's in the assessment and plan, remember the acronym MEET. Remember that the codes are reportable at least once a year. So if you have the patient come in annually for their Medicare annual wellness visit, that's a great opportunity to review all of their problems and update the status of them. Other things that the auditors are looking for beyond the composition of the note is, was the note signed properly by a qualified provider? And some of these audits are finding that the medical record does not have a legible signature or the appropriate credentials. And these audits that are bringing these things to light are called Risk Adjustment Data Validation, or RADV Audits. These audits are being done to ensure, CMS is auditing Medicare Advantage plans to make sure that they're accurately being funded, and the Medicare Advantage plans are auditing the providers to make sure the documentation supports everything that we've just discussed in the last 5 minutes or so that needs to be documenting so that you're compliant in your coding, comparing that to the medical record. So Medicare Advantage plans can be audited annually, and the Medicare Advantage plans can audit the providers annually as well to substantiate the coding. One of the good things to do to document that you're doing your best to be compliant in your office is to do an internal audit. And if you don't have the resources, get a consultant to come in and do a RAF audit for you, and then use the findings from that audit to educate your clinical staff on doing a better job for their documentation, to make sure that they are documenting all the current conditions, that they're documenting the status of chronic conditions annually, that they're only coding signs and symptoms if a definitive diagnosis doesn't exist. If a patient comes in with a fever and a cough and they're sent for a chest x-ray, the diagnosis for that encounter has to be fever and cough because there's no confirmed diagnosis of pneumonia. Also, reminding them as a result to code to the highest level of specificity, major depressive order versus just saying depression, or morbid obesity versus obese or overweight, and coding all coexisting acute conditions. If a patient develops complications such as protein-calorie malnutrition, that would be an additional diagnosis, and code the status of any pertinent past conditions such as patient having an old MI. Looking at the medication list is a good way to remember all the conditions for which the patient is receiving those drugs, and making sure that they are listed in the assessment as well. Looking at the orders for any tests or for any referrals given, and documenting the conditions that were the triggers for those requests for services also should be listed in your assessment and plan, and coding all the status conditions, making sure that the long-standing things such as amputations, acquired limb, dialysis, HIV status, the note should say the patient has angina, they're stable on nitroglycerin, or that they have compensated CHF, they're stable on Lasix, or they have COPD and it's controlled with Advair. That's a much better way to document it than just listing the drugs that the patient is on. Though that type of documentation would support these things as a reportable diagnosis. So to summarize it, do you have a compliance program? Are you looking at your risk adjustment audits to validate clinical documentation? And have you done that? And if you have, did you use the audit results to provide education to all the clinicians and the coders in your practice? And also, don't forget about the importance of the documentation supporting the CPT codes that you're reporting, as well. This conversation has been focused on the diagnosis codes, but both the CPT and the diagnosis codes need to be accurate and supported by documentation in the notes. So monitor the patient visits to ensure that you're getting them in annually. Use your appointment list, run reports by diagnosis code and last service date and insurance, and then get a list of all the patients who are in your Medicare Advantage population in your practice. Run them by the diagnosis codes for the HCC categories that you have decided to report for in the coming year, and then make sure that they have an upcoming appointment. And if they don't, assign a staff member to call those patients and get them in so that you can assess those conditions, report them on an annual basis, and maximize your RAF scores. At this point, if you have any questions, we have a few more minutes left, and I'd be glad to have them open the lines up so we can take any questions you have. If you have a question, you can type it into your text box on the right-hand side, and I can see it.
So Nancy, what I think we'll do in the interest of time is if people have questions, feel free to reach out to your Triarch territory manager, and we'll make sure to get answers to you, or reach out to Triarch support, and we'll be happy to get back to you. We want to thank Nancy for her time today. We also want to remind everybody to please sign up and register for next month's Wednesday webinar. We'll be reposting today's webinar on our YouTube site and channel, so please make sure to go there if you have or would like to review today's session. Additionally, everybody on today's session has qualified for the Amazon Echo drawing, which we'll be doing via Facebook Live, so please visit our Facebook page for more information on that. Other than that, we look forward to seeing everybody in February, and again, if you have questions, please reach out to your territory manager over here at Triarch. Thank you, everybody, for your time. We appreciate it.
Thank you.
Thank you, Nancy.